Good afternoon, everybody. I'm just going to let everyone join before we start today's ePrescribe Masterclass. Hope everyone's had a good morning so far. I'll just give it another minute before we start. Right, good afternoon, everyone. For those of you that have not joined the ePrescribing Masterclass before, I'm Anna Patel, pharmacist working in the digital medicines team at NHS England. It's great to see so many of you today for October's Masterclass. And for those of you that want to know a bit more about the purpose of the Masterclasses, the aim is to break down silos of working and actually share experiences from organisations in terms of their implementation of digital technology to help support others to follow. Today we've got 3 great presentations lined up for you. The first will be a pharmacy terminology update from Paul Wright. Then it'll be the electronic prescribing risk and safety evaluation, the ePres tool launch. And then finally we'll be joined by digital implementation of ARC by Laura. And in terms of the platform itself, if you do have any questions, please make sure that you put them in the question and answer tab, which will be on your tool panel, and then after each presentation speaker I will ask the questions that are in the questions box. And in terms of the recording will be available after today's masterclass on the NHS Futures website for those of you that want to refer to it. So I will now pass over to Paul, who will give an update on pharmacy terminology. Paul, over to you.
Thank you, Amna. Can you hear me okay?
Yes, we can, Paul. Thank you.
Thank you. Okay, thank you firstly, Amna, for having me on the session today. Good afternoon, everyone. So yes, I'm Paul Wright. I work in NHS England in the pharmacy terminology space. And today I've got a few updates regarding the NHS Dictionary of Medicines and Devices, the DM&D, and also around some SNOMED-CT terminology. I was last on one of the webinars here in May, and I given an update around a survey that we were going to release around uplifting the DM&D standard, Sky 0052, and a survey that was going to go out to users to understand the impact of doing that uplift. And then also there was a SNOMED-CT consultation that I presented on as well at that point. So those are both on this deck today as an update of where we are with this, and there's some other information as well to share with you. So I've got about 5 to 10 minutes to do that. So next slide, please. So the first thing I wanted to make people aware of was that actually we've added some new content to the DM&D recently. This is ingredients VTMs that we've recently added into the DM&D, and that went live in the DM&D TRUD, which is how you can access the files back on the 23rd of September. This is new content that hasn't been available at this level before. Previously, ingredients have always been authored for VMPs, but not at VTM level, and so the VTM ingredient link information couldn't ever be derived from content that was in DM&D at that time, but now that can happen. So VTM can at times have an ingredient that is a level of abstraction above a VMP ingredient, for example bases and salts. So that's why we've added this content, and it's also going to help with modelling and classification of the SNOMED-CT drug extension, which is our other terminology product alongside the DM&D. So we have added oh, if you could just to go back a slide, sorry, like this. So we've added VTM for ingredients, as I said. It's gone live. It's provided as an additional bonus file within the DM&D weekly extract for people that want to use it. At the moment, we've gone live with ingredients for a number of VTMs, and what we're going to do is it's a static file that's gone out first and foremost, so that people can see it and they're able to view and understand what information and data is in there first and foremost, and see how that may be useful to them. And what we're then going to do is gradually update the remaining number of VTM ingredients and to populate those as well. And what we'll do is we'll come out and we will communicate as we start to do that, and also once that process has been completed as well. The VTM ingredients will be available from TRUD. It won't be seen, however, in the DM&D browser until we start to update those remaining VTM ingredients, and we're looking to do that over the coming months. So at the moment, you won't see VTM ingredients in the browser, but they are there obviously to access from the files. And we do have a very specific web page on this that you can access, and that'll have more information, and we'll update that as we move through all this work. Next slide, please. Thank you. So, as I said, I presented on this survey that we were going to release around uplifting the Sky standard. So, uplift. What we mean by uplift is update. Okay. So we have run that survey. It went out between May and August. It went out for a while because during that period the election was announced, and so we had rules on what we could circulate information for and not. And so whilst the election period progressed, we couldn't actively promote it. So what we did is just extended the amount of time that people could feed back once the election period had been completed. And we went out to users to understand the impacts of updating the scope of Sky 0052. And this is really a technical change around the files that people download and how they access them. So the scope for updating the standard, there's a few things here. So there's the DM&D historical codes, which have already gone live in DM&D, so they're available as a kind of a bonus file. We've got the ingredients for VTMs, which I've just mentioned. They're now live in DM&D. Next year, we're looking to add trade and trade family group, currently within the SNOMED content, but not within DM&D. So that we're expecting that to happen in 2025. But also we had interesting excipient information in DM&D up until October 2022, and that hasn't been in the extract since that time. So it's an empty field, and so what we want to do is just remove that to clean it up. So currently, all the historic codes, the ingredients for VTMs, and when the trade family group go in, they're all supplementary files or bonus files. And what we want to do with uplifting the standard is to reflect those changes as part of the core DM&D data model within the standard, rather than currently being a supplementary file. So it's trying to bring all that data, all the work that we're doing to add content to the DM&D into the standard, rather than adding things as extra files all the time. So we ran that survey. We've got really good feedback from users across different sectors. So primary care prescribing dispensing, secondary care prescribing dispensing, automation, but other research, data analyst organizations, and both from technical colleagues and also from clinical colleagues as well, which was great. So we took the findings from the survey to the content committee, which oversees the governance of DM&D, and they've agreed for us to proceed with uplifting this standard. So thank you to everyone who contributed to the feedback. We really appreciate it. What we now are is that we're in a queue now with updating that standard, and we're not expecting it to happen until 2025. We need to make sure that all those ingredients for VTMs go in, and we also need to go live with the trade and trade family group. But also we need to go through our standards assurance process within NHS England, and at the moment they're going to be prioritising the work next year. So we're getting ready to start the process, but it's going to be into next year. And what I'll do is I'll make sure that people are aware of this work as we get more concrete information on timeframes, etc. And basically as part of this, what will happen is there will be a dual running period of the files, of the current structure of the files, and then of the files as they will newly look once the standard is uplifted. And normally we run that dual period for 6 months, but feedback that we've had from the users is to ask for that dual running period to be at least 12 months, so that they can transition over to the new file structure. And we will do that. And as I said, all our information will then be available on our website. We have a project email address that anyone can ever ask questions and talk to us around this if they're unsure of what it all means. Next slide, please. And I also wanted to give advance notification of a survey that we are looking to put out to users of both DMD and the SNOMED C2K drug extension in November to seek views from users of those terminology products regarding their release cycles. This is an opportunity for users to highlight preferences of the release cycles. It doesn't necessarily mean that those release timings will change. What we're wanting to understand is if there's appetite to change those release cycles. But if there are, then we will need to do further impact analysis with other areas to understand that before we go forward. What I mean by release cycles is when the new data is made available. So currently for DMD, that's released every week and it's released on a Monday. But the SNOMED C2K drug extension, that's released every 4 weeks on a Wednesday. And then within the DMD, we hold drug tariff information from the NHS England and Wales drug tariff. Now that's published on the 1st of each month. So we've got 3 different time frames here, and depending on where DMD also is within its release cycle, there can be a time lag between drug tariff information being available and represented in DMD. So what we're wanting to do is go out with a survey to get an understanding of preferences. It may be that people don't want the change in the release cycles, that they want to leave them as they are. It may be that they want the release cycles of these terminology products to be more frequent or even less frequent, and that's what we're going out to understand. Even if we are looking to making any changes to the release timings, again, that wouldn't take place into summer 2025, so it wouldn't be for a while. And again, we would also be very clear and communicate with users as to when that will be. And again, we will have a website which will be updated regularly, so people will have up-to-date information. And obviously, I can come back and present here and let people know what is going on in of the findings of the survey, etc. Next slide, please. Thank you. This is my last slide. This is in relation to some work that SNOMED International are doing, and the reason I'm presenting this is because it's one role I have within my role is also being the UK member forum representative for SNOMED International, so that's why I'm presenting this. So SNOMED International are proposing to increase both the maximum length of their fully specified names and synonym descriptions from the current 255 characters to 4,096 characters. The requirement for this has come from the pharmaceutical and biological product hierarchy, and it's particularly due to the number of ingredients in multivalent vaccines. So I had previously presented on this in May, and SNOMED International had a deadline at that point of the 31st of July for feedback from UK stakeholders. SNOMED International have then made the decision now to extend the deadline, so that is now the 31st of December this year. And they have also released further information about that, which is available in the Delon link, which I've got on the page. So NHS England continues to collate feedback, which will go back to SNOMED International and will inform our view from the UK around this particular proposal. So if SNOMED CT content is being used in your system, this could impact you. SNOMED goes ahead with this. So I urge people, if they can, feedback in the survey that we have by December. And if you have any questions, then please do email us. At the moment, from my understanding of all the feedback that's going on around the SNOMED community, the UK has provided the most feedback. So it's really great to see the involvement of stakeholders putting their views in, both as a technical change, but really in other areas such as the clinical impacts, the clinical safety impacts to the usability of interfaces, etc. with this. So if people want to reach out to me, then please do through that email address, and I will receive those and can talk to this. That was all I had, Amna, and I'll answer any questions if there are some now, or people can email me and I can look at them at another time through that email address.
Oh, that's great, Paul. Thank you for the update. And for those of you, the slides will be available on the NHS Futures website. So I know Paul had some links to websites, so you'll be able to access them after the masterclass. So thank you, Paul, for that update. I will now go on to our next presentation, and this is the electronic prescribing and safety evaluation version 3 launch, and I will hand over to the ePres team. So this is Stephanie and Jamie and Andrew. So I'll hand it over to you all. Thank you.
Thanks, Amna, and it's lovely to be presenting on the masterclass again. Thank you for inviting me back. We may be short because Jamie's having the usual fun that everybody has with GoTo, but if he can dial in, then he may be there just to speak to his slides, so we'll keep an eye open. Those who are listening to the call will probably remember, I hope will remember, that we involved all of you several years ago in pulling together the first version of ePres and then the second version, which ran over the course of the pandemic. It was designed by yourselves with a view to helping people to understand how they might locally improve configuration of their electronic prescribing systems to really address known prescribing risks. So the really common stuff that we all know about, making sure that we use our systems to best effect, so we don't do stuff like once daily methotrexate and similar things like that. So the tool has now been iterated into a 2024 version. We're looking to launch this again today and really help you to help yourselves identify where you're doing really well, where you've put a lot of work into optimized systems, but also to maybe help you highlight where there are areas that you might need to think about improving, or there are opportunities to improve to prevent harm. This is about an approach. It's not about individual tests. It's about looking at the overall approach that you're taking and thinking about the thematic learning that you get from actually undertaking the tests, and then going back and looking at how you're actually managing and optimizing the system that you've got. What we will do when we've run the test this year is we will actually collate all the learning that there has been, so see where people are doing well, where they're not doing so well, and start to ensure that we can share that across all of the people that have participated in the test, so that it supports you to improve, but also to support new implementations and so on as well. So we have now run this twice. We've had a pilot version in 2019. We ran it over the course of the COVID pandemic, and we've now got a version that we've spent a lot of time actually thinking about the feedback that people have given us and improving it. We keep going, Steph. So the findings from last time through, so why have we kept going with the tool and actually thought about rerunning this? What it showed us last time round was that all implementations across English hospitals are really not equal. It recreated work that was found in America over 13 years ago and found huge variation both within individual system providers and between different system providers. So there was huge opportunity there to actually improve the performance of electronic prescribing systems. And we found a huge variation between the participating trusts of between 20 to 73%. So some people were doing very poorly, some were doing very well, but nobody was mitigating, as we might say, at optimal level. And that means that from those organisations using the same electronic prescribing system, there was a variation between 20 to 73%. So it's not the system, it's the way the system itself has been set up and the way it's being used. The best clinical decision support category that had consistently good mitigation scores was actually allergy. But again, there was a huge variation with 0% for one system and 100% for other systems and vendors. So even allergy, which is the most basic tool that I think we'd all look to have running within our electronic prescribing systems, was not consistently good across everybody. By vendor, was there any correlation between good mitigation and over mitigation? Well, analytics found strong correlation between good and over mitigation. In other words, nuisance alerts or too much information coming through and annoying or disturbing the prescriber, meaning they're less likely to respond to any information that's provided. And bear in mind, this is not just about alerts. This is about supporting prescribers to make sure that they make the right decisions. And alerts is the last way that we would want to do that, but inevitably it's part of the equation for certain decision support. So it does show that you might score very well, but there is absolutely a balance required to optimize systems to ensure that in scoring well, you don't actually create a lot of noise and therefore make it less likely that prescribers are going to respond. We had 5 very high risk mandatory questions that we looked at that everybody got as they were running through the test last time. 5 mandatory questions and 35 random questions. And what we wanted to do was actually look at whether just those 5 high-risk questions have been a focus for certain sites and people were doing extremely well. So things like valproate, insulin, methotrexate, and so on. And worryingly, I think I can say, is that there was variation in optimization to fully mitigate those risks as well. So there is work to be done, this would suggest, at individual sites to look at how they actually think about managing electronic prescribing systems to reduce the risk of medication error. If we move on. These are the actual scores or the results that we actually had. If you look at the left-hand graph, green mitigation, a good mitigation are the green bars, no mitigation is the orange, over mitigation is the red. So you can see that good mitigation for the actual systems was not that great. It's about 50–60%. And so EP1 to 13 are the different vendor systems that are available out there, and you can see the mitigation scores across them. So we haven't really got any one system that's standing out above all the others as being particularly better. And for the 5 high risk questions, so this is the methotrexates, again exactly the same systems. Not all of them are, not all systems are performing particularly well. The best that we had for them was 60-odd%. So you can see there is huge concern, if you like, about the fact that just the high risk questions, never mind the rest, are not being particularly well mitigated across the majority of systems in England at the moment. Next screen, please. So next steps suggest that we are not doing as well as we could be. We're not mitigating known prescribing risks as well as we might be. Mindful of the patient safety agenda, the impact of variation on implementation and quality safety, and of course the fact that people are on journeys, we know about, but it shows that there is a lot of work that still needs to be done by end users to actually get us to the point that we're really getting our electronic prescribing systems to sing, and we're getting the best out of the investment that we've all made, not just in the systems, but also the time and effort that we've all put in to actually optimize and configure systems. There are no national standards for electronic system implementation or mechanism for assessing EP systems at the moment other than ePres. And mindful of all of that, that means that we've therefore now done an awful lot of work behind the scenes, taking the feedback from the last version of the system to actually launch version 3 for this year. And that will then happen today. And that's what Steph is now going to talk about and explain all the work that's been done to actually move this forward, so that we'd like to invite you at the end of this to take the test and see how well you're doing in the work that you're all doing to manage and optimize your systems. So Steph, over to you.
Okay, thank you, Anne. If we go to the next slide, please. Right, so I'm just going to give you just a quick run through about what we have. We just go back a slide there, thank you. So some of you will have used the tool before. Just want to let those people know that they've used it before, and those that are coming, that the tool it's much more robust this time. We've done a lot of technical stuff under the hood, as it were, to make sure that people can move more flexibly, that the tool is easier to use and user friendly. As Anne said, we've taken on board a lot of the feedback, and we've done quite a bit of sort of user acceptance testing and those sort of things to learn. about the tool and learn how users, work through it. We have obviously enhanced the content, so we've been working with MSOs, volunteering to help us, and we've also tried to introduce new mental health prescriptions tests into the tool this time. That was one of the things. As we move forward, we're going to try and increase the breadth of prescribing risks and content in the tool. Obviously, the generation of new content, we've got to manage it through a good quality assurance process, and we really tried to set up expert clinical reference groups this time to identify new risks, sort of based on your lived experience and sort of knowledge of patient harms that are happening now. And we've used that sort of bank of people to generate the assessments. Additionally, they participated in peer review process. So as we're going through, we're making sure we're checking everything, making sure it's relevant and it's accurate and the outcomes. And obviously, all of that work has been sort of supported by our clinical lead, Jamie, who unfortunately is struggling silently to hear, or he would be speaking to this. So if we have the next slide, please. So as Anne said, we are really pleased to be able to release the next version that it is available from today, and that's where you can register. What we're going to do now is we're going to run through and explain a video, which is a short video, assuming we can get the technology to work. So I think Anne's probably going to have to come back on screen, and then we'll just let you watch the explainer video that just takes you through all the steps that the tool takes you through. And this is available also on our information website, which I'll talk about shortly too. So if we can stop there and let Anne take control to play the video.
ePres is a web-based tool intended to help NHS hospital sites assess and evaluate their e-prescribing systems to support optimization and reduce harm caused by adverse medication prescribing events, improving patient safety. This is an annual assessment that can only be completed once each year by an individual organization. It is not possible to access the tool multiple times and overwrite previous attempts. The tool provides users with a set of 15 fictional patients, which users set up in their live or test prescribing environments, and then provides a set of 45 prescribing scenarios to challenge their system responses to risk. There are 5 configuration tests looking at specific build issues. Version 2024 is suitable for all sites actively using electronic prescribing systems for adult patients. To access ePres and registering for the first time, go via the website. The ePres application is compatible with all modern browsers, including Google Chrome, Mozilla Firefox, Opera, Safari, and Edge. To register for the first time using the 2024 version of the tool, enter your NHS email address, select the trust name that you work for, and create an account password. Click the Register button to confirm. You will then be directed to the login page, where you will be able to log in with your email and password. Once successfully logged in, you will see the ePres homepage. Now let's have a look at the buttons below. About describes the background of the ePres program. Instruction describes main steps in the tool. Reports. This is where you'll find your completed summary report. User Guide offers a helpful starting point before you begin an assessment. And Contacts. Any questions or help required should be directed through the email address on screen. Please note, office times are 9 AM till 5 PM Monday to Friday. You can expect a response between 48 and 72 hours after submitting an inquiry. Now we'll go through beginning the assessment. Please complete the background questions, ticking all that apply. Some secondary questions may appear conditionally on a yes response to a previous question. Part 1 of the patient build is where we'll create patients with name, date of birth, and gender. There are 15 fictional patients to create. The assessment can be completed by an individual or teams who have the access and capability to be able to use their electronic prescribing system to admit or edit patients and prescribe medicines. This should be done using your normal method of admitting patients, for example, EPR or PAS system, before medication can be prescribed. Once the basic patient information is entered into your selected system, please click Done at the bottom of the page to save this set of patients to your Trust's 2024 assessment. Part 2 of the patient build is developing the patient profile by adding comorbidities, medication history, and any relevant clinical data. Pull up each of the newly created patients one at a time and add the information to each one as presented in the ePrescribing tool. When you have worked through the 2-part build of the 15 patients, the next button will change to a Done button. Make sure you click this to save your progress through the application. If possible, you need to add clinical information for each patient onto your system. You may need help from other individuals in your trust. It is important to check everything has been entered correctly. We acknowledge that user systems vary and not all information present may be enterable. In this case, please let us know by leaving a note in the comments box. Current estimates suggest it takes roughly 1 to 1.5 hours to set up the fictional patients. You can log in and out of the patient build sections without losing your place so that it can be completed over a number of different sittings for convenience. In the final stage of the application, you are presented with a series of tests. Tests should be carried out in consultant status to avoid formulary issues. There are 45 scenarios to complete, plus 5 configuration questions. In each test, you are presented with a specified patient name from the previous setup group of patients. Select the appropriate patient from your test environment and prescribe the medication exactly as detailed in the scenario presented. Record the relevant advice or information that you receive while completing the test by selecting from the system response options available on screen. Always check you have selected the correct patient. Don't forget, there are tooltips available on options to describe system response. If the system response option selected is you were able to complete the prescription with system user intervention, you will have to record whether an alert or advisory response was given. The yellow box explains what advisory and alert means. Please complete the checkboxes. This is to allow the user to record which clinical decision support category the intervention made is best described as. When selecting a clinical decision support category, please do not select more than 2 categories. When you have completed the test, click Next to ensure that your response is recorded in the tool and that you can move on to the next one. A tooltip is also available for this section. Please note, once you have clicked Next, you will not be able to return to this page again. For example, you cannot redo a test. Please discontinue the prescription order in your EP system before proceeding to the next test scenario. There are 5 free-format general configuration questions appearing in the assessment sequence. These are yes, no, or not applicable answered questions. Please respond appropriately before moving on to the next patient scenario. On completion of the assessment, your individual report will appear. Reports are composed of 3 sections. 1. A summary pie chart of overall mitigation results for the user's EP system. As part of the pie chart, there will also be a matrix. This matrix is used to help users understand the pie chart results they have been provided in their report. 2. A table-based summary of results on the number of tests taken, specific information on any extreme risk not mitigated by the user system, summary results on high risk and detailed report on the outcomes of the 5 configuration questions. 3. A stacked bar chart of mitigation results within CDS categories. By hovering over each bar, the user will be able to tell how many questions were executed in that category. The report is printable. You can also save it as a PDF. Please note, you will have access to your trust's test data only. We will be analysing factors from all of the collected data as part of NHS England's drive for patient safety. Thank you for watching.
The things that we just want to flag up before you start the assessment is just have a think about, can you create things? So part of the tool is you have to create 15 patients, fictional patients, that the tool will give you. You create that in your live system or your test environment, whichever you're using, and then you run your tests against those. So part of the setup is just to think about what access have you got. Would you normally put your patients into your PAS system or your EPR system, pull them through? How would you work? And just think about how you will mimic that when you're doing the tests. So you ask you to think about that. Are you going to use the live version or your test? If you're going to use your test, then it really has to be exactly the same as your live, otherwise you're not going to get an accurate reflection of how well your prescribing system's mitigating against the risk. So just have a think about those things. Just have a check about any browser requirements. The tool's being tested against all of those listed, and there shouldn't be an issue. Usually the access issues come with any firewalls, whatever you've got within your trust. You do have to have access to the Health and Social Care Network, the internal NHS sort of like secure system to get onto the tools, so sometimes that can cause issues. And also what we're suggesting is that you do make sure that your team in pharmacy and your CIOs and those sort of things, that people know that you're doing this test. Just it's good that they understand what's happening and that you're going through this process. Next slide, please. So again, what would you like to do? This would have been the explainer video, but just good, we've got a recap here. You can register with the tool. It's at that address there. You complete some general questions, some general profile questions. We'll ask about what system you use, how long it's been in place, when it was last refreshed. A few questions about how many people are sort of involved with setting up and maintaining your system, and where your electronic prescribing system is used. Is it used in all departments across your organisation or just in some, and that sort of thing. So just collecting some background information, a bit like the DMA assessment. Then the tool will provide you with some 15 test patients. Everybody gets a slightly different set of patients, and you build those as guided in the video into your systems, and then you run some prescribing tests against those patients. So you go in, you pull up your new fictional patient, and you're asked to prescribe a particular medicine line. We ask you to try not to have your pharmacist or your clinician heads on there and just prescribe exactly as it is, because the test is designed in a set way, so it's easy to autocorrect. But we try people to just sort of like just go with it and prescribe as we've asked you to do. As you go through those tests, we're asking you to record how your electronic prescribing system works, or put in a response. So you might prescribe a line, nothing might happen, and that's fine. You would click into the sort of like boxes in the tool and record nothing happened. Your prescription went through. Something might happen. There might be an intervention, might be an alert or an advisory pop-up, and in that case, you will tick the button that says we've got an intervention, and then you get a drop-down list of things that are split into clinical decision support categories, drug age, drug labs, those sort of things, and you would select whatever that response that you could see was, and it might ask you whether it's alert or advisory, and you can put additional information in there. We're not asking people to overthink it. It's very much instinctive. I prescribed this, the system told me, the dose was too high or whatever. Just select what your gut instinct is on that. There's no particularly right or wrong answer in that section. We're trying to learn, and the tool's still developing, so trying to understand how people categorize interventions and that type of thing as well. At the end of doing all of those sort of things, and it's only going to take you probably, I think on the user acceptance testing, it's been taking people probably about 2.5 hours to do the whole thing, so a lot better than it was in the previous versions. So the patient build, probably the longest bit, probably an hour and a half, and then the tests. So as soon as you finish the assessments, you will get your report, and that will be an individual report. You'll just be able to see your own report. And the report will break down into tell you how many high-risk scenarios you were tested for. It will give you some feedback on a few configuration tests that are in there, which are things a bit more about how your build is. And if there are, again, like in the last tool, 5 mandatory questions, which are extreme risk. And if your system doesn't mitigate against those properly, you will get immediate feedback on that. So then you will know you've got things that you can work through, and you can fix straight away on those ones. Next slide, please. So these just like a few tips, things just to know. If you were in last time, this is a duo. We've completely redone the tool, so you've got to register as new. You can have up to 4 people register with the tool for your organisation. So you can have more than one person going in and building it, or maybe accessing the report at the end if they want to. If you want to, your managers or whatever to look at the report, then they can access it. You can't go in and do this over. You can't go in and look and play with it and run the tests. Once you've built your patients and you've done the assessment, that's it, done. You can't go back. You can't, try to change anything and that sort of thing. Once you've done your test, each test, it's saved, and then you move on to the next test. So it's not a sort of thing where you can go in and out. The only bit where you have flexibility is the first part where you're building the patients. This is, as I've just said, this is an annual test. It can only complete it once a year. And the next one is patient. Yeah. And as I said, you can go in and out of the tool for build patients. Sometimes one of the questions we got asked last time was, we've got lots of different systems, which one do we test? Just test your most commonly used prescribing system. We haven't got, the tool isn't advanced enough yet to do different types of systems for the same organisation, but that's something we're thinking about in the future. As I said earlier, the tool is only accessible to those on the HSCN, so that's mainly NHS England trusts. And there's no way around that at the moment. And the other thing is, it launches today. We're open for a week, so a period of about 6 weeks. So we'd like people to complete it by the 30th of November, if possible. So it's not as long protracted process as it was in previous years. So 2 or 3 hours, hopefully the test can be completed in. But by doing this on a campaign basis, it means we've got a window of time to collect as much data as we can and get and analyse and get the feedback sorted. So if we can just move to the next slide, please. Right, so we've got a website set up for general information, so you can go back in, you can go and look and find that video. So just go into that site, epraise.info. There's FAQs on there, there is the video, and there's a PDF user guide again, which you can use with the video, just to have a quick look. Work through it to see what to expect, and when you build patients and do the tests. And then if there's anything outside of that, any queries you've got, there is an email provided there. You just click into that and that will come through to the team. We'll try and respond to your queries with about 2 to 3 days. Obviously Monday to Friday, probably quicker than that, but we will try and help people with any access issues or anything else they want to ask us about the tool. And then we come to the last slide, please. So thank you for listening. We're really keen to get people engaged with this. We're really, sorry we couldn't show the video today. Please go and have a look at it. This is what our strapline implementation is, only the start of the journey, which I think is really what Anne talked about at the beginning. It's just about getting that optimization, and we're trying to learn and help you learn as much about, what makes a good system, what makes good mitigation. And that's it.
Thank you, Anne, Stephanie, Laura and Andrew. There's a few questions that are in the chat box, so I thought if I could just go through a few of these. There's a question around if you need to have the lab results included in the prescribing system to run the actual test, if that's needed or not.
Andrew, do you want to take that one?
Yes, so I hope I'm replying appropriately in the tool. So some of the tests do have lab results as part of the assessment, but obviously we're conscious that not everywhere has got lab integration, or that you may not be able to input lab results for kind of test patients. So there's a question at the start that asks whether you have lab integration with your system and whether you're able to enter them. So we capture that, and obviously we use that to then interpret the kind of the results, because there's no point punishing for someone if they can't physically kind of do that. But actually that might then be a driver to say, well, actually, let's have a push to get lab integration in, because it's a critical part of decision support. So this is around, not hitting anyone, but what do we need to go and focus on in our kind of next 3 to 5 year journey as an AP manager, and maybe lab integration is kind of part of it.
Yeah, that's great. Thank you, Andrew. There was just another question from Melanie around, they're in the process of setting up ePMA for the first time, and are they able to register and use ePrescribing if they haven't gone live yet, to see how well they're set up for the ePMA system? Would they be able to use it even if they haven't gone live?
I think the answer to that is probably yes, but we might want to look at pulling the results to one side, clearly, because what we don't want to do is skew any learning that might come out of it. So Mel, give me a shout and I'll talk you through and we'll see what we can set up.
I think just on that point, one of the things, Jude went around and did some observations of people going through the tool, and ideally what we want you to do is do it in the live system, because that reflects day-to-day practice of your prescribers, but that isn't always possible, and sometimes you may need to do that in your test system. So I guess in your case, if you've got a pre-production that's ready to go, that's as close as you're going to get. But when people are interpreting the results, if they have to do it in a test system, always be cognizant of what's the gap between where I am in pre-production and where I am in live, and interpret results with that in mind.
Thanks, Andrew. There's another question around what's the implication for the trust if the results show risk. So if this is an NHSE assessment, does this need to be added to the trust risk register to acknowledge? And is the data and risk held anywhere centrally by NHSE?
This is possibly, as Jamie, are you still online? Maybe not.
Yes, can you hear me?
Yeah, do you want to take this one?
Yeah, so we've had fairly clear steer as a board that that this isn't to be used as a performance.
Oh, we lost you. Jamie, we've lost you. Okay, so following up from that, this is not to be used as a performance management tool. And we've had a very clear steer that that's the case. This is a tool to help individual sites optimize their systems and reflect on and learn from the results that they get. How you choose to use that at a local level is entirely up to yourselves, but we will not be sharing details in any way, shape or form that could be used to enable this to be essentially a performance management tool. So it's entirely up to individual sites to make that determinant for themselves. But we would hope, obviously, you would look at the results and reflect on what you're seeing and think about how you use them.
Thanks, Anne. And then from James, I think they've said they've had a firewall problem in the past because of where the ePres website is hosted. And the questions around, could it be relocated somewhere else? I think you did put something on the slide, Stephanie, I think, on one of the tips slide about how to actually try and access the tool, if you wanted to just reiterate that.
I think that one of the requirements was that we have to host it for security reasons on the HSCN. So we're sort of like, the only way to get around that, if you can't access it, it's possibly because your trust's blocking it in some way. So you log a ticket with your IT department and ask them to help. And just why I'm on this, some people might have issues accessing the ePres info site, because again, some NHS sites don't like it. That's actually sitting outside of the network because it's just a general website. So if you can't access it through your NHS, you can probably just pop it in your own browser on your phone, and you'll be able to access the video and the other things there easily.
Okay,
but not the tool, unfortunately. The top tool has got to be through on the HSCN. So yeah, check with your IT department, get some help from there.
Yeah, that's great advice. Thank you, Stephanie. And then there was a question around, is the system talking to the leading UK drug dictionary provider about over mitigation around the licensing may preclude some on-site configuration, and whether there was work looking into that?
So this is a difficult one, isn't it? Because this is about local configuration. So I understand why people might be thinking about that, but as we said earlier on, this is not necessarily just about alerting. What we would hope is that systems are being set up in a way that alerts are the absolute last opportunity. And yes, I agree, whilst we all know about that, sometimes that can be difficult. But if you are finding that you are getting a lot of noise with things being turned on, then we will obviously look at that as we see the national picture. And yes, we will talk to the third-party providers if we think that's part of the challenge and the issue that there is. But think about it from your own perspective in terms of how you've got it switched on and configured. Andrew, do you want to add anything to that?
No, I think that's the point. A lot of the ability to kind of meet what ePres is testing you for is around your local config. If you switch everything on, you run the risk of over mitigation. If you're doing it in kind of a more considered way, you're making those local decisions which are outside of what the vendor's recommendations might be.
Thanks, Anne and Andrew. And in terms of the links, I know Stephanie put a few different links and emails on the last slide, which that slide will be shared on the NHS Futures webpage for those of you that have attended the webinar today, in case you do want to get in touch about using the tool if you've got any questions. And also there is the link to the video that's been put in the answers, the Q&A section, for those of you that want to actually go and view the video. And I think that's most of the questions that we've been able to answer for today. So thank you, Anne, Andrew, Stephanie, and Jamie for launching the ePres, the latest ePres tool. Hopefully you'll get quite a lot of user engagement from it, and we'll see you probably for the next relaunch if there is another one. Thank you for that today.
I think we might come back and show you some results, hopefully, and share some of the learning, if that's okay. I think that would be really good. This is about people learning from the way they do it, so it'd be great if we could come back and do that when we see what people have done this time. I'm hoping it's much better than last time. I'm sure it will be.
I'm sure it will be, Anne. And definitely, like I said, we can have you back to share those results when they're ready to be shared. Thank you. So we have our next presentation, and I'll hand over to Laura to share information around the digital implementation of ARC. Laura, I'll hand over to you now.
Lovely, thanks very much. So if you move on to, I've just got one slide today, so very, very brief overview. So this is about using digital systems to optimise antimicrobial stewardship. Obviously, antimicrobial resistance is a big risk. We know 30 to 40% of our inpatients are on antibiotics at any one time. So it's a big sort of cohort of patients that you can affect by improving prescribing practice. This is sort of a continuation of the ARC study, which was a step-wedge clustered randomized controlled trial across 39 acute hospital sites. And what it was trying to do was, antibiotics are often started in a real period of uncertainty, but they're reviewed at sort of 48 to 72 hours, but more than 95 prescriptions continue. And one of the big barriers around this is that care is quite fragmented. There's that lack of understanding about people's thought process in starting the antibiotics, and that leads to reluctance to kind of change what's already been started. This trial, so the intervention was around some education, some audit, but primarily use of this tool about trying to define what you're thinking, how certain you were about infection and the need for antibiotics at the point of prescribing, and building that into the sort of 3-day review. And what it actually achieved is it significantly increased the proportion of antibiotics that was stopped at this review period, and in some instances up from sort of 5% to 30%, so really significant, and achieved a sustained reduction in antimicrobial use in the organisations that sort of fully implemented this. And interestingly, we've just had a national action plan for antimicrobial resistance, where the target is that we should be reducing antibiotic consumption by 5% by 2029. So there's probably something here about implementing this intervention effectively in the current landscape that will really, really help our work around AMR nationally and for our own organisations. This was largely done in the paper prescribing environment, and there have been real challenges in implementing this in the new sort of digital landscape. We have got this post research implementation development grant from NIHR, and we've been doing a bit of stakeholder engagement already around this sort of antimicrobial stewardship community in terms of rethinking the educational tools, redefining how we describe this intervention. But what we're really lacking, and what I'm reaching out to people for today, is from this sort of digital community in terms of how we can bring this into the current digital landscape and create and implement solutions for this, optimising the review of antibiotics in the digital systems. So the ask is there's a QR code and there's a link that will go out with the slides that I can also pop in the chat for users to engage with this process. And really it's a bit as much or as little as you like. We've got some focus to our workshops on the sort of digital systems with the sort of biggest market share coming up at the beginning of November. We'd love to have EPMA pharmacists, pharmacy technicians, that kind of team involvement in that. As I've said, we're quite heavy on the AMS expert side and less so on the digital and informatics side. But if you can't make those workshops, or you are working in other sort of digital environments, then there is still loads of education engagement opportunities, and that can be as much or as little as you like, you know, just commenting on things sent out by email at a time suitable for yourselves, rather than engaging in sort of 2-hour workshops at a fixed time. So happy to take any questions, happy to talk to people in more detail about it, or if there are quick questions now. There's also a link in the slides for our sort of trial website, so there's more information where you can access the full sort of research paper and read a bit more about what's happening, if that's of interest to you.
Thank you, Laura. I'm just going to see if there's anything in the chat. In terms of, you mentioned, so this QR code link, is that just for the specific workshop signups? Or as you mentioned, if someone is just interested to know about what work is going on and may not be able to attend these, is it the same sign up link for those that just want some more information?
The sign-up link will take you to a little form which gives asks you to give a little bit of information about yourself, so we can direct the sort of best possible information to you and sort of involve you in the right sort of parts of the work. So it's not limited to those 3 workshops. You can sign up for that even if you're using a different system, or you can't make those specific dates, and get involved as and when over the course of the project.
And I think there's just it might just be a small typo just around the dates. The 4th, is it? I think it may be supposed to be the Monday rather than the Tuesday, or maybe it's supposed to be Tuesday.
Wednesday, Thursday. If I've done those dates wrong, just let me double check.
It might just be a typo.
So yeah, sorry, that is a typo. I did this slide very quickly this morning. So Tuesday the 5th, Wednesday the 6th, and Thursday the 7th. Apologies for that.
No, that's great. Yes, so the dates are the 5th, 6th, and 7th for those of you that are interested. And yet, please do use the QR code and sign up, because, as Laura said, to get the engagement from digital leaders would be great for the project, in terms of making sure we have the scope of different professionals as part of the work. So we'll make sure that this presentation, Laura, will go up on the NHS Futures website, so people will have access to the link from there. And if you do want to put the link actually in the Q&A, so people can access it directly whilst they're in the call now, that would be great. So do we have the next slide, please? Thank you, Laura, for today. And in terms of, we've had 3 different speakers today, and I hope you've all found it useful in terms of what has been presented. And if you do have any feedback, then please do email Sarah, that's on the page there. And if they have got any future topics that you would like to be presented at the ePrescribe Masterclass, please do let us know. Or if you would like to present some of the work that you're undertaking in your organisation, again, we're always grateful to hear from speakers and to share their innovations and use of technology. So reach out to Sarah, and then we can provide you with dates for future masterclasses where you'll be able to present at. The next masterclass is on Wednesday, the 20th of November. There's the QR code there to scan on screen. And for those of you that have attended today, you will get a certificate which will be emailed to you of attendance. And the presentation, as I've already mentioned, will be available on the NHS Futures website alongside the recording of today's session. I don't think there's any final questions, so I will say thank you for everyone for attending. Thank you to all of our speakers today, and I look forward to seeing you at the next masterclass in November. Please do get in touch with Sarah if there is anything that you'd like to feedback or present, and I will see you in November. I hope you have a great rest of the day. Bye, everyone.